Welcome to Psychoanalysis You, the official podcast of the American Psychoanalytic Association. I'm your host, Dr. Gail Saltz. The American Psychoanalytic Association is the largest U.S. member organization of professional psychoanalysts, and this podcast will highlight the work of various member analysts and how that work can be of use to you in your day-to-day life. So today, I have Gila Ashtor with me to talk about some very topical and current terms that are used and treatments for the problems that they cause. Very excited about that. She is an assistant professor of clinical psychoanalysis at Columbia University. She's also on the faculty of New York University's postdoctoral program in psychoanalysis and psychotherapy, and at IPTAR. She's the author of 3 books, Homo Psyche on Queer Theory and Erotophobia, which won the MLA's Alan Bray Award for Best Book, and was a finalist for the Lambda Literary Award, Exigent Psychoanalysis, The Interventions of Jean Laplanche, and Oral History. She's currently at work on a book about what she's calling feeling disorders, phenomena such as gaslighting, empty consent, and toxic relationships that combines her interdisciplinary expertise. Her primary areas of interest are academic and expertise, including dissociative disorders, trauma, and sexuality. And she's in private practice in New York City. But today, we're going to talk about these feeling disorders. And I think most people would be like, what is a feeling disorder? So why don't you start us off with your definition?
Yeah, I think that it is a new term, and the way I'm thinking about feeling disorders is a way to capture a whole series of phenomena that are instances in which there are disturbances in the process of feeling, of having one's feelings. So I'm thinking about empty consent, gaslighting, toxic relationships, imposter syndrome is a chapter. All these instances in which I'm hearing patients talking about losing themselves in a relationship, losing a sense of themselves, being autopilot is another one. These very strange experiences that are not part of our psychoanalytic or just general mental health terminologies. They're not official terms. These are terms my patients are coming to me with, my students. But they are affecting, as far as I can understand it, their capacity to have their feelings, to access their feelings, to know what they feel, to express what they feel. And we can talk about this in more depth. I'm not sure if I'm answering the question too deeply, but also I'm trying to describe how it's an experience at a deeper level than we're used to thinking about. It's not merely that a patient or a person has their feelings and they're not expressing it because they're repressing it. They're not having those feelings.
Okay. Meaning they're not having those feelings at all, or they're having feelings, but they're so unconscious for them that they're not accessible.
Yes, that I think in different instances, different things could be happening to the feelings, but we are more or less in the mental health establishment, psychoanalysis, including operating under the assumption, mistaken, I think, that everyone more or less knows what they feel.
Okay.
They know it on some level. They might not know it consciously, but even when we say unconsciously, we kind of assume somewhere in their mind they're having that feeling. And what I'm seeing with something like gaslighting or, empty consent, they're like, no, I really had no idea what I felt, or no, I really wanted what I thought I should have wanted in that moment. How could I have secretly wanted something else?
Okay.
Like, how could my feelings have gotten so far away from me?
Interesting.
And so these are, I think, experiences in which it's beyond what we're trained to look at, sort of in terms of the feelings being there, just being deeper, or being in the unconscious. They're either not developed in the first place, they're not allowed in the interaction. We have a lot of terms for this psychoanalytically. They're not formulated in a person's mind. So all these experiences in which it's not good enough to ask a patient with ever increasing frequency, like, no, but tell me what you really might be feeling underneath that. Like,
they can't do it.
They can't do it. It's not there.
Right. And that's part of the disturbance for them.
Yes.
So let's talk about that. If they're not feeling, and therefore they're not suffering necessarily, right? What brings them into treatment?
It's a great question. I mean, I think oftentimes what I back into this problem, like with feeling disorders, as it were, I back into it in the sense that a patient comes in just saying with a general feeling of stuckness, or my career is not taking off, my intimacy, my attempts at intimacy aren't working out, I'm up for anything sexually, professionally, whatnot, and yet nothing feels right or feels real. It's like a diffuse sense of lostness or alienation, no big trauma for the most part, no major crisis. I don't know that there's even so much urgency. It's more that what emerges in the course of treatment, partly because of the way I work and partly because of, I think, what they're presenting with, is a sense in which they're just generally disconnected from what they're feeling. Like
So we're psychoanalysts.
Yeah.
How do you distinguish this from, say, someone who's presenting with a dissociative disorder or feelings of depersonalization, derealization? How do you distinguish this from someone who's presenting with flat affect or anhedonia? Just I don't take pleasure in anything. That can be symptoms of their own disorder or symptoms of, major depression or some other disorder.
One of the things that kind of set me on this path, it's a long answer, but is I was teaching writing classes at Columbia in the MFA program. These are writing students, not clinicians, not in therapy, writing books. They're writing fiction or nonfiction. But they kept writing about toxic relationships, empty consent, gaslighting. It's in every book. They're writing about this. And they're trying to understand what's going on with their characters. And I was like, well, I don't know what's going on. I don't know what that term is. I know dissociation. I know derealization. I know depersonalization. This stuff I know psychoanalytically. What you're talking about, I don't know. These are not clinical phenomena. I don't know how to deal with this. And part of what I saw over years was that I think they're using words that are actually trying to describe something a little bit different. I think it's an ordinary dissociation. I think we're trained to look for something quite extreme. I mean,
real pathology.
Real pathology. The dissociative disorders you and I are trained to identify usually have some trauma somewhere in that story. They have some, however, capital T, lowercase t, whatever you call the trauma, they have some history of neglect in some form, abandonment. We're talking about patients that are pretty high functioning. Patients that are they're in graduate programs. These are my students. These are like creative individuals. They have access to creativity. They're in relationships. They're extremely verbal. They're extremely articulate. They don't meet any of the checklists. They would pass any test for dissociative disorder in a certain sense. They can speak with a lot of warmth. They're interpersonally warm. All the things that we look for, I think, would not turn up these kinds of issues because these patients are very adapted to the society they're in and they function very well. The sense of something being off is very subtle.
Okay. So this is Freud, in a way, really designed this treatment for everyday human suffering.
Yeah.
And you're saying these experiences fall into that rubric of it is causing them suffering. It is causing them dysfunction even in their lives, but it's more of the everyday variety.
Yeah, I think it's the everyday variety that we've sort of trained ourselves out of seeing because we've gotten so caught up in some of the more vivid, extreme presentations. And so we're looking for kind of more pathological, pathogenic cases. And these patients are fine. They're just, I think this is something I was talking about yesterday. They're fine, but they're also not actualizing their potential. They're not, they could have more meaning and more depth and more intensity in their lives. They could be more creative, creativity in whatever form. It's not that so even when they're suffering, it's almost like they're suffering from the life they could be living, if that makes sense.
Yeah, they're not, they have limited self-knowledge, right? Which is something that psychoanalysis as a goal has to increase your self-knowledge. And therefore, relationally. They have more shallow relationships, I gather, is what you're saying, and sort of not reaching their potential in terms of vulnerability and therefore trust and true intimacy and all of the things that we say give life value and meaning.
And I think one of the ways we can think about this as an ordinary problem too is, you think about technology, you think about capitalism, you think about neoliberalism, you think about the way that the ordinary individual today is trained and shaped by these forces to sort of not even want more intimacy or creativity. The dissociation is so compatible with the society we're living in, where you're supposed to be satisfied with
looking great on your Instagram
as long as it looks
right?
good,
Right.
and as long as I see this with my patients with sexuality a lot. They have the sense, especially my female patients, that as long as they're being adventurous sexually, as long as they're up for anything, that means they're sexually fine.
I see.
They're like, they shouldn't want more.
It's not about their personal experience of like feeling close to that person and vulnerable with that person, loved as they are, and
vulnerability, surrender, intensity, being rattled, being shocked, the kinds of things that you want sex to do. They're like, no, but as long as I'm not too attached and I'm fine. And it's like, wait, is that enough? And it's not enough. I think they are suffering, but I think they don't even know how to formulate that suffering. So I think you have things like empty consent, often these words. And
so,
yeah.
Define empty consent for us.
I have to look at my chapter because it took a long time. But I think of empty consent as sort of where the technical criteria of consent was met.
Yes.
But the feeling of wanting it was absent. So you have situations with, I think we can all think of, I imagine, but where I find my patients describing like, it's my fault, or I don't have a right to be upset about it because I did say yes.
Okay.
I said yes. But now that I look back at it, that was awful. Or I don't know that I even wanted that. Or I don't know why I went along with that. Or what the hell was I thinking?
Okay.
So
internally, they didn't really consent. But in the moment, they were so out of touch with that.
That's right.
That they gave the go-ahead.
That's right. And so technically, it doesn't show up as a problem.
A crime was not committed.
A crime was not committed.
But internally, for them, a crime was committed.
And so, exactly. And so how do you understand what happened in that? And so we're relying in the mental health, field is relying on like a legal definition of consent here, which is ridiculous. It might be what you need legally. I'm not an expert, but it certainly doesn't help us psychologically.
Yeah.
Because legally this person did consent, but does that tell us that's what they wanted in that? Like, they are out of touch. They don't know. You get caught up in the roles, in the dynamics, right? All these things
So let's say the person that comes in and says, I had an experience, it's really rattled me. I can't stop thinking about it. I assume this is sort of how they present. Yeah. I don't know if I can trust myself because I gave an answer and it wasn't the answer that was a good answer for me. Mm-hmm. And so now I don't know about trusting myself. I don't know about trusting others. I don't know about being in a sexual situation. And you identify this as this common phenomenon you're experiencing of empty consent. What, as a psychoanalyst, do you bring to bear on how you treat someone like that?
I mean, I think that the most important foundation of this work, and I think it feels radical to say this, although it shouldn't, is that as a psychoanalyst, I value that they will be connected to themselves. And I don't think that everyone values that. But I think psychoanalysts do, and we ought to if we don't enough already. There's a way in which the priority of treatment has to be that we are facilitating a patient's encounter with themselves, with all of the mess and the complexity and the nuance and the otherness that entails, but that they are more truly themselves. Mm-hmm. And I think a lot of other treatments are not oriented to that. Mm-hmm. They are oriented to solving the problem, to a lot of what my patients come in with. You say they present that way. I think patients present a little differently. I think they'll say something more like, I have to have better boundaries. I need to, I've seen these things online. I've read stuff that posts and videos. I think if I had better boundaries, then I would be happier. What's wrong with your boundaries? Well, I just keep getting into situations that aren't great. I feel like if I had better boundaries, they come in with the solution. That's the problem.
Okay, interesting.
The problem is that they're led down a path of thinking that the solution is to shut down more of their ways of relating or more of their openness because they don't know how else to cope with the fact that they find themselves repeatedly in situations that are missing out on who they are, untrue to who they are. So it's more that the work is more to say, whoa. Like, before you got to the solution of needing firmer boundaries, or not going out at all or shutting down. What is the problem that's presenting?
Mm-hmm.
They don't formulate it as a problem. Or I think about another way this presents so frequently is a patient I have a sense that a patient is describing like an unsatisfying encounter with someone, but they're not saying it was unsatisfying. I can just feel like I don't think that felt so good, but they're more like, I was at a party and and then I did that and I guess it was fine. And I'll like rewind and be like, wait, so what do you think you were feeling then? I don't know, nothing, like nothing. Could have been feeling nothing. Like, you try again? You're like, what do you think you were feeling?
Mm-hmm.
Or are you feeling before? And they're like, what are you bothering me? Like, it was fine. It's this like tracking, this going back and then be like, oh yeah, actually, I was kind of upset before I did that. Why did I go along with the thing? I did just want to go home.
So
it was
basically
11 o'clock. I was tired.
Someone comes in and has erected a set of defenses to an experience, and they come in with a solution that is more defenses.
Yes.
And so your work is basically exposing those defenses that they have been doing, that those are defenses that are maladaptive.
Yeah.
And trying to give them insight into that.
And I think that patients, and this is where I think social media and maybe the therapy culture we're living in is complicit a little bit with the problem.
Absolutely.
Because patients are having the idea that it's normal to be disconnected from yourselves. They're not expecting anything better. This is what I think, like, psychoanalysis, if it does anything, it's like we should come with the expectation that you deserve better. Like, you deserve to be disconnected. You deserve to be connected to yourself. And if you're not, that's a problem. Mm-hmm. And I don't think other people are saying that. I think they're giving patients drugs. I think they're giving patients, techniques or workbooks, which we can do whatever suits you. My point is more that we're kind of accepting an ordinary level of disconnection from oneself. And I think so these patients are like, so I wanted to leave at 11, but then he wanted me to stay, so I stayed, but like, whatever. Well, why whatever? What does that mean, whatever?
Do you think that these are old phenomena that we just didn't label before? Or do you think that sort of this generation grew up on the internet, social media, and so that outside societal forces have created this, that these are externally acquired problems?
I mean, when I have been talking about this in the past, I get this question a lot, and I have people of a different generation are often like, there were toxic relationships a long time ago. Nothing new about a toxic relationship. Right. And I'm like, of course there's nothing new about a toxic relationship. Go to Shakespeare. Like, it's all, this is not a new, of course, phenomenon. Who could say otherwise? And yet, I do think there's something about developments in the economy, in culture, social media, tech. I think even feminism. I think these are very enlightened, empowered women. So there's a real like, what? I'm doing this? Like, I'm empty consenting? Like, I don't think I'm worth less. Like, the ways that we think we've gotten around the problem have not helped us enough.
Okay.
So you have a lot of women, I'm finding particularly with women, who are just shocked that they're in these positions. Like, how could I be gaslit? I know my opinion matters. I don't think men are better than me. Like, I think I can be a girl boss, and yet I'm gaslit, right, left and center. Like,
so let's talk about gaslighting, because that is probably the most ubiquitous new term on the market. How do you define it, and what does it look like when patients are coming in with you about it?
Gaslighting is very pervasive, and I think gaslighting is an example where it might have existed all the time, but I do think it's gotten also more pervasive. And I think, how could we not think about tech and media as a way in which we are constantly being asked to override our own sense of reality?
Well, we're literally, with AI and video and curating, being shown not real reality.
Exactly.
So it certainly feeds into this problem.
It does feed into it. I think of gaslighting as a situation in which you are essentially being asked to cede your own sense of reality for someone else's. So accepting someone else's perception of reality over your own. And I think people talk about medical gaslighting, people talk about this in politics, people talk about this interpersonally, but I think of it as as a way in which we are underestimating how susceptible we all are to gaslighting.
Mm-hmm.
And that is something that we are newly, I think, thanks to psychoanalysis, honestly have more appreciation of than ever before, understanding the dynamics that undergird interpersonal relationships, understanding how sensitive those are, how nuanced those are, how you can adapt to another person instantaneously without even knowing it, unconsciously, unconsciously, for so many reasons, not just survival, but also comfort and connection and so on and so forth. And so I think that
that it's about gradation.
Yeah.
In psychiatry, we've long talked about folie à deux.
Yeah.
But we talk about that in someone who can be psychotic, truly psychotic with a break with reality because of an internal process.
Yeah.
And we talked about many of these things, but only as you're bringing up in this really pathologic sphere.
Yeah.
So, but even at this less pathologic level where someone doesn't have true psychosis, people can still be convinced or at least left unclear about what is reality.
And that's, I think, how it often presents in practice. You'll have a patient who has no other, pathological problem, or there's everything else is moving along fine, as it were. And yet they'll be like, I don't understand what just happened with my husband or with my partner or with my business partner, or how did I fall so deeply down a well of forsaking my own sense of what I think or want or believe. And so these are situations in which it's not only that it's not extreme, but it's that it can coexist with a lot of other things that are totally normal and ordinary. And so you don't need to be crazy, or you don't have to have something crazy happen to you to be gaslit. It's not just some person and some type who's susceptible. There doesn't have to be prior trauma. I think psychoanalysis and all of God, the amount of videos I've seen online about trauma. And I don't want to take trauma. We can't even think without trauma. It's more like we're still looking to pin this on some original trauma. No, life is actually so complicated and so messy that you don't even have to have trauma. You are just an emotional being, and what it requires to be a feeling being is so complex that you can lose yourself easily.
So your task is, how do you help a patient to become both vulnerable and porous enough to know themselves and have those experiences that are so important in life to live their best life, as you're saying, but at the same time, reality test and not be so porous that they're not susceptible to this sort of, truly susceptible to this sort of, they may have the experience, but they're not truly so susceptible. So how do you do that as a clinician?
This is last week. I had a consultation with a patient who it was a new patient. I don't know her. And she was talking about having been in treatment many times, having had good experiences with treatment. She feels she's really articulate about her issues. She feels like there's nothing major, but she's about to engage in certain major leaps life-wise in terms of her partnership, in terms of her job, and she feels kind of uneasy about that. And as she's talking, I'm feeling like, okay, this is all very rote, very ordinary. She sounds very comfortable in everything she's saying, but I'm not getting a sense of risk or vulnerability or aliveness. It just feels like it's too smooth. And also, keep in mind, she's presenting as someone, she's saying, I've often had these very good enough experiences with treatment, but I want something more. And I stop her mid-sentence and I say, what are you feeling right now? And she's like, now? I'm like, yeah, right now, 11:52 a.m. What are you feeling? And she's like, I don't know. I was like, try. It's you're an articulate person. She's like, oh, I think I feel a little bit of X or Y. And I said, why this? Let's go down this thread and let's go down that thread. And then she starts saying something about something else. I didn't care in that moment about any of her life history. I don't really care that much about her goals. I just want her to have the experience at this moment of being having a feeling and being connected to me in that moment. And we had this very engaged session, and she talked about other fears and other concerns. And I said to her at the end of it, how did that feel? We're out of time. And she was like, I've never had that experience before. I thought, I have one session with you. I might never see you again. I just want to get you curious about yourself.
Mm-hmm.
That's like my only job. I don't need to like reveal something important about your unconscious. It's going to take years anyway. I don't know that I'm going to like cure anything, but can I get you to be curious about like how you feel and how you might feel if you were in touch with your feelings? It seems like that ought to be the goal, but that to your question, that's how I work. Like, how do you, I think our job, and this is something social media, thank God, and chatbots, thank God, still can't do. Like, how do you get someone curious about themselves? And how do you get them to think that their own mind is interesting? And I don't,
Interesting or not too dangerous.
Yeah. So you have to make it, you're talking about how do you make it safe enough that it doesn't, that the ways in which, because it is too dangerous too. Like, but how does it feel safe enough to go there a little bit? Yes. And that calibrating that balance between safety and risk, right? I think sometimes, and this is what I hear, I mean, we saw there's an article in the New York Times last week about chatbots, or the Journal. Chatbots are just validating machines, just validating.
It's a large language model, and that's their goal. Right?
But then the onus on psychoanalysts now has changed. Now we have to do more than we had to do 10 years ago. We can't just be validating anymore. The chatbots can be validating. So if we want to do something, I think we have to now like step a little bit outside our toolbox and be willing to be a little more engaged with our patients, because validation they can get online in the comfort of their pajamas while watching Netflix.
Obviously the cliche of, and
yeah,
that's interesting. And
you must be feeling X.
Right.
That must be hard for you.
Right. Which is really not the way psychoanalysts truly worked, even before, but certainly not today.
It wasn't, but we have used the way we've relied on this. I don't want to, get into the weeds of it psychoanalytically, but I think we've said we don't work that way because we were like, well, we work 5 times a week.
Okay.
But now we all end up working 1 time a week.
Right.
You can't do deep unconscious work 1 time a week. So now we are doing what everyone else is doing. A lot of the time we're like, that sounds hard. I wonder if, how that makes you feel. There's a certain way in which we have gotten, I think, out of necessity, out of whatever, I don't know. It's a whole other conversation as to how and why, but I think we're not pushing our patients enough with skills that, yes, we uniquely as psychoanalysts have, because we know there's an unconscious. Like, we know there are these dynamics, and I think we have to we realize that our time is really limited.
To be more active.
Yeah, and their attention is really limited, and the competition for what can help them is extremely fierce. Like, they can get shorter answers, quicker solutions much more easily online.
Sure.
So if we want to help them, if we want to get them to be curious, get them to be brave enough to withstand the risk of encountering the danger of their own minds, we got to like act a little quickly. Like, we got to move a little bit.
Does that channel into sort of providing insights more, sooner in a treatment?
I think of it as time with my talk. I think it's also, yes, but I think it's also about being willing to be present ourselves and be a little more alive. Like, I think, with patients, I will often find myself saying, like, you're not angry about that? I'm not saying you have to be, but because if I'm thinking there's a missing feeling there, I don't have 10 years to wait until they see that. I'm like, I'm feeling like I wonder if, and not to say that we need to go down the path of my feelings, but more, could this be a model of a way to think about how you could be feeling, So just this way of putting ourselves there, not interpersonally, like we're not talking about me, but more just what feelings could you be having in this moment, or what is possible for you to feel. So I think something where we're taking a little more risk ourselves too. I mean, not just putting it all on the patient.
Not the blank slate, but bringing more of ourselves to the treatment.
I think a new version of neutrality. I still think it requires a lot of discipline to not allow this to turn into something that is interpersonal in a certain sense. But I do think it's about being willing to, I think for lack of a better word, like be alive in the room with the patient. And I have candidates asking me all the time, like, I'm sitting there months on end, crawling out of my skin, frustrated, nothing is happening, but I don't want to interfere. And it's like, why are you sitting there months on end, frustrating, crawling out of your skin? Like, you have to work with that, like engage the patient.
So another topic that you do talk about and perhaps pertains to what we're speaking about now and is very much in the zeitgeist is this question of toxic relationships, which, has really been watered down to, anything that makes you miserable.
Yeah.
Gets to be called toxic relationship. And of course, there's also this rise in estrangement in families and as the solution to the toxic relationship. So that's very concerning, obviously. And I'm not saying that there's never a place for a relationship to become so toxic or really, I would say, abusive that it's perhaps not safe for a person to stay in a relationship. But speak to us about that. What
toxic relationships, was one of the unwieldy of all my chapters, the most unwieldy, because it's something that is so complicated and because you want to somehow find a way of holding a place for both relationships that are abusive, but also understanding that sometimes change, sometimes, is rooted through some pretty painful experience. And so sometimes the only way to grow is to endure quite a bit of pain, which is a necessary repetition. And so if we are jumping out of situations every minute or as soon as they become painful, I don't know how we're going to grow.
Right.
I really
well, it's hard
worry.
to have a truly intimate, vulnerable, and mutual trust relationship without having gone through some difficult bumps and perhaps some future difficult bumps. But how would you define a toxic relationship?
I think of a toxic relationship as a relationship in which the painful repetitions do not lead to positive transformation.
Okay.
And so the fact that there are painful dynamics on its own, that's not convincing me that's a toxic relationship, because it would take some time to see if that's really just going in circles, in which case, you're not growing, you're not learning anything. This is just about pain. That's abusive. This is a toxic relationship versus, but you're getting somewhere. You're slowly getting somewhere. Also, people are attracted to the very things they need to work on. Like, I have tremendous faith in the ways people choose their objects. Like, and even when it looks like, God, why did she choose him? I'm like, you don't know. Like, people are fascinating. People are interesting. People have complicated stories. Like, they choose the objects they need on some level. That, though said, they still need resources to be able to work with those objects. And it's not clear that always works, as you know. So I think
and sometimes they are attracted for exactly the reason that you say, in a way that, of course, really futuristically for their own mental health is never going to be okay because they are repeating a trauma.
Correct. And I think of it as one of the things I talk about in the book is the relationship between like glitching and decoding. I think of this as a term like glitching is like it's just on repeat. It's not getting anywhere. Okay. That's so it's a toxic.
We would call that repetition compulsion.
Yes.
But yes.
Yes. But that term has become so problematic. But yes.
Okay.
In the academic journals, we call it repetition compulsion. But I think of it as like glitching where it's just getting stuck. It's getting stuck. And versus like, no, it feels bad and no one's happy right now, but they're getting somewhere, or it's not the same it was 2 years ago, or something is coming out of it. And I think that takes a lot of care to see. And again, social media, but you don't have the time and attention to look at something. If you're just like hot take, like that looks bad, get out of it. I mean, like,
right.
That
which there are many life coaches and whatever, armchair mental health professionals very happy to tell you, while they're doing a dance or whatever it might be, that is the case. So the advantage that psychoanalyst has is this person is sitting with you over time.
Yeah.
And you can, your aim is to help them discern, is this toxic? Is this glitching?
Yeah.
Right. Or has there been growth here? And how can I help you have more growth in this relationship?
And psychoanalysis, I think, is also has a lot of faith, I should say, in a way that other fields don't in unconscious processes, but like by definition. And so we believe that there's something in the mind that is doing something for some reason. We might not know it, but we believe there's a reason. And I think that faith in the unconscious enables us to take things seriously in a way that I think a lot of mental health is just very dismissive about, like, oh, if it's not obvious why you're doing this, it must be stupid. And it's like, what are you talking? Most of the important stuff we do is not obvious. We're driven to it. I don't know why we're driven. Like, it's complicated. But so I think that there is this, I think psychoanalysis is willing to put in the time, but also it just believes. It believes in the mind in all of its like kind of wonder and complexity in a way that I think people need, like, in order to
So is most of the work that you do with these kinds of issues, is it experiential in the moment, in the dynamic between the two of you? As you said, well, that would make me angry. How do you feel? Let's get in touch with how you feel. How much of it is psychoeducation of exactly what you're talking about now? You have a dynamic unconscious. Let's try to understand the things unconsciously, which may be driving you toward this particular relationship. What is sort of the...
Yeah, I don't know. I think the ratio, I mean, I think a lot of the experiential is just to like get them interested, just to be like, you have an unconscious, you have a mind that's pretty interesting, actually, despite what you're being told, actually quite fascinating. I think that some of that's just to get them interested, but I think a lot of psychoanalytic theory, I think I'm just willing to meet a patient where they're at. And I think I'm like willing to kind of do a lot to get there. And so I don't feel like I can just sit back and wait for the patient to free associate. I'm like, if I have to come and get you, and all you're talking about are TikTok videos, we'll talk about that. Or you're talking about boundaries or estrangement or like all, I'm willing to.
So what do you find are obstacles in treating patients who come in with one of these kinds of complaints?
I think the biggest obstacle is that we don't take it seriously. I think the biggest problem is these patients are self-diagnosing because we don't have a way of explaining that it's a deeper issue. So I think one of the biggest obstacles is that we don't take it seriously, and these patients don't feel seen by the establishment or whatnot, by a lot of mental health. And I think a lot of and I think some understanding that patients can be self-sufficient, high-functioning, articulate, and still have huge pieces of their sense of self totally missing or impaired. I think we assume that if someone seems like it has it all together, that they're fine enough, right? Because of this idea of what's pathological.
Meaning they don't deserve treatment or they don't need treatment, but
they don't need anything that intense. Like they just need to get better, do better boundaries or have better boundaries or, sleep more, or have better sleep hygiene or cut off their parents because their parents are bothering them. I mean, whatever, that there's some quick fix because they're fundamentally fine. And I'm like, no, if you're detached or disconnected from your feelings, you're not fundamentally fine. Something like huge is wrong. You could still be fine in all these ways, but I have patients, you talk about autopilot. Like I have patients who can go through their lives. I have patients in their 50s whose kids have left the house and they're like, what have I been doing for the past 30 years? Now, it doesn't mean they've done anything wrong. It's just, whoa, like I can have one identity and then not recognize myself. And where did the rest of it go? And these are things people are talking about a lot. And this is like, was I an autopilot? Was I detached from myself? Am I still there? So, I mean, that's another example where it's sort of ordinary and normal, but also serious and deep.
What component of this is sort of, when I think of my practice, and has to do with a patient's capacity for, you are using the word feelings, another word would be affect, but their ability to tolerate strong affect or versus they're not experiencing affect at all. How much is it working with the patient on being able to tolerate bad feelings so that they can be in the experience? If their thermometer is like, I only thrive between 70 and 72, how much of it is that?
So much of it is that. So much of it is, and this is to your point earlier, your question earlier about danger, right? That a lot of the ways people develop is to adapt themselves to a very narrow range of affective life, and that they are scared, and that fear is reinforced by parents, by family, but also by society of like anger is bad. And if you're a woman, you definitely shouldn't be angry, and you definitely shouldn't have all these feelings. And there are a whole other set of feelings too. And it doesn't require much to reinforce it. Who wants to be angry?
Right.
It sucks. I don't
or
like
unhappy for that matter.
Or unhappy or scared. Like, we also don't want to be those things. You don't need someone to tell you. It doesn't help that everyone tells you not to do it. But so I think a lot of it is allowing, and this is where it goes back to the experience piece, allowing the patient to have their anger, let's say let them be angry with you. I mean, this is something psychoanalysis cares a lot about. Like, why don't try it with me? Like, let's see what happens. Let's see if you can survive. I can survive your anger, I'm pretty sure. Let's see if you can survive being angry. Oh, like, we got it to 73. Like, you just had an experience where the thermostat like crept up to 73, 74, like, and you survived. So I think a lot of that's again where the experience of treatment is so alive. It has to be. Another thing the chatbot can't do.
So
right?
the in vivo relationship of the therapist or the analyst and the patient as the model, which has always been a cornerstone of psychoanalytic treatment, is so important. That experiential transference that the patient has to you, and being able to not have countertransference, so having had your own treatment, so that you can respond and show that patient that's data about them, that's information about them that they should be curious about and absorb into their thought process.
That's right. And where psychoanalysis, because we are trained to prioritize the relationship and to work with it, where, yes, it doesn't go down this route of I'm taking your anger personally, or I have to defend myself. I don't care. What I care about is your experience of anger. Because if we're thinking about treatment and a treatment goal is about enabling a person to come into themselves and become themselves, then all that really matters to those ends are that you have a deeper engagement with yourself. I'm a vehicle for that, but it's not about how your anger makes me feel. I mean, that's interesting. If one day we want to think about more of the unconscious dynamics of all of this, I can store that information. But for a lot of patients, often what matters most is just the experience of their anger and what does it mean? And does that make them increasingly able to have anger at their jobs when a coworker does something annoying, or have anger at I mean, you talk about the family estrangement. I mean, maybe if they could have more of their anger, they wouldn't need to cut off everyone that upset them, right? I mean, it's kind of tragic what's happening in many ways.
So you try to give them the insight that, anger's a feeling, or thoughts are thoughts, and they're not dangerous in and of themselves as long as you understand what's happening.
And that you need muscle, that you need to build muscle to sort of withstand your own feelings, that you need to it is going to feel scary the first, third, 10th time. But over time, and we're going to keep doing it, it's going to get to be something you are more comfortable feeling. Yeah, and to see that over years and to see how that progresses. I mean, I do think psychoanalysis is unique in that way. We're not trying to rush them out the door. And we can tolerate, I think, that they don't have that the solution is not instantaneous. A
tough thing to do in society today.
Getting
with
only
insurance
tougher.
Companies telling you it needs to be instantaneous, and people having the expectation that it should be instantaneous.
But that's why I think, some awareness and some communication to the patient that, this initial moment of helping them feel aware of their own aliveness. The reason I think it's so important is because that gives them something to look forward to. There's more of that. There's more you there. We haven't found it yet, but there is more you there. And I think that that's what enables patients to keep going, even though there's not an instant fix.
So in that sense, what do you think the treatment goal is for someone who, we used to call this the walking wounded.
Yeah.
Right. You're doing the things in life you need to do. Nothing is a disaster, but our job is to reduce your human suffering, not eradicate it.
Yeah.
But reduce it. What is the treatment goal, do you think, for these patients?
I think to facilitate their own increased like aliveness, vitality, experience of themselves. I think aliveness is something that's actually not a value. Like for the most part, I think society is perfectly happy for us to be like the walking dead, really. Like maybe the walking wounded is the Freudian equivalent of the common unhappiness. We get them from
boundaries.
dead. Yeah.
Everybody's very
boundaried and
siloed and
atomized,
affect dampened,
glued to their phones, glued to their screens, no attention span, no capacity for complexity, nuances out the window, no patience. I mean, it's so much easier for society to control people like that. We don't want people who are messy and conflicted. And
yet we are living in a time where there's certainly a lot of affects, messiness, anger.
Yeah.
And, I guess you might even say toxicity that we're witnessing. Is that, how much does that serve to be, let's say, frightening the population into being constricted versus how much is the population aspiring to or wishing, at least unconsciously, that they could partake of all of that in a way which seems maybe powerful, or, at least the joy of being self-referential. If we sort of expand this out, your topic, into sort of the larger society we live in, what sort of messaging can we offer as psychoanalysts to a society where there's this deep divide between leaders or certain people who are elevated and represented to all as a model, who are exhibiting all of this in certain ways, all of this emotionality, and put it out there and be who I am, and versus what you're seeing.
Yeah. I mean, I think what one of our messages as psychoanalysts has to be that we want to help people feel their feelings more and more deeply. And I think that a lot of what we see and a lot of that really damaging, toxic, destructive behavior is a defense against a lot of feeling. I mean, the defense is what kills us, as we know, not the disease, right? Always in psychoanalysis. It's the defense. It's what you do to destroy the painful feeling that is so destructive. It's not the painful feeling. You can tolerate a lot of excruciating feelings, actually, if you can just stay alive through the feeling. And so I think that what we have to offer is a kind of training or kind of immersion in some kind of experience of feeling your feelings, and hoping that enables people, believing that enables people to be more both resilient but also more flexible, more porous, like porous not being a bad thing, a good thing. What you see, I think, with a lot of the people you're describing, or people in power, is they're refusing to have feelings. They're refusing to they want to be transcending sort of human emotion. This is what happens when you try to do that.
The behavior is actually what happens, right? Instead of thought and feeling, behavior, and they're acting out.
And destruction. Because you're trying to destroy the complexity. Like, complexity humbles us. It makes us have to not know quick answers. It makes us have to pause and be like, I have to weigh that. I don't know. So all of that goes out the window when you're just trying to avoid feeling. So yeah, I think hopefully it gives us a little modesty. I think that's absent, needless to say, from a lot of places, and it's certainly not going to be cultivated on its own. So maybe that's something psychoanalysis can offer too.
Well, we look forward to your book coming out.
Thank you.
And meeting people where they are now, which is an evolving place.
Yeah.
So thank you.
Yeah,
thank you so much for joining me today.
Thank you. Thanks.
Thank you for listening in today. We at the American Psychoanalytic Association hope to introduce you to the many ways psychoanalytic thought affects the world around us, and especially you, through this podcast. We would love to hear your thoughts, questions, and requests. If you haven't already, please subscribe to this podcast on your favorite podcast platform. Follow APSA on Instagram, Facebook, LinkedIn, or X at psychoanalysis_ with the hashtag APSA podcast. And feel free to send a question or comment. You can find more information about the American Psychoanalytic Association by going to www.apsa.org and listen to more episodes and find bios of our guests online at apsa.org/podcast. If you found this episode useful, please share with a friend or colleague. And we will be back next month with another episode of Psychoanalysis and You. I'm Dr. Gail Saltz, and it's been my pleasure to be your host of Psychoanalysis and You. And now for some Freudian quickies. You sent in your questions for an analyst. I grabbed an analyst with an answer. Till next time. Can a joke ever be a joke and not about sex or aggression?
Well, absolutely. You think back to Freud's wit and its relation to the unconscious, a lot of jokes are funny because of the element of surprise, particularly the surprise of discovering something that you already knew but hadn't quite articulated for yourself. So yes, there are a lot of things that can be awfully funny, and some of the funniest things are the things that surprise you.
I think it's fair to say that I don't know. I would have to think more about when it is that I find a joke funny and I don't think it's about sex or aggression. Is it actually on some level about sex or aggression that I'm not appreciating? It's a great question. I don't know if I have a great answer.
That's a great question. I think a joke is both told and understood by the listener. So if the person tells the joke and it has unconscious aspects of sex and aggression embedded within it, but that joke teller is not aware, one could argue that it's there. It could be that both the joke teller and the joke listener are not aware of the sex and aggression within it. So then the joke is just a joke, I would say.
Humor is a part of being human, and there's a lot more to being human than sex and aggression, even though those are very important. And so it could be either or both of those. It could also be a lot of other things, and it could also just be a good joke or not a funny joke.
Is there more than sex and aggression? Come on. Okay.
Resonate.